link. I'm sending the link. Okay. All right. Good afternoon, everybody. We have got thank you and welcome to the this month's CME.
Amit, you went blank?
I don't know why I went blank. Sorry. Okay, so we have got Dr. Anjali Gulati, cardiologist in San Francisco area, interventional cardiologist. She's going to speak on. She's very passionate about heart disease in women, and she's going to be enlightening us. And I learned yesterday from a little. CPR session which I had that women
Amit, again, your audio is breaking up.
the
Amit is breaking up time to time.
Okay, give me a second. Give me a
Okay.
second. 1 second.
Okay, meanwhile, I'll finish my part. So thank you guys for joining the CME. Dr. Kavita ji has done very good job. She has 3 eminent speakers, and this is Women's Forum, so she's going to take the lead. And they will have a session. Probably she will talk about she's planning for our convention. And so we're also in the process of planning the CME for the convention. If you have any suggestions or something, please let us know. But I'm going to not be here for a while since I'm working, but Amit is going to finish his part, and then we're going to go and give it to Dr. Jyotula. Go ahead, Amit.
Okay, sorry about that. So basically, this is very exciting because we have got different type of CME. We are concentrating on women's health, and Anjali, I'm sure, will tell you a great deal. But I learned yesterday that heart disease and heart attacks, when they happen in women, they have a different set of symptoms, and I'm very keen to hear that. Apparently, like the typical chest pain radiating down to the left hand is not common in women, and they have got a different thing. So to be aware of that part, and I'm waiting for Anjali to enlighten me on that. We've got she's a board of trustees and of AAPI also. We have got board of trustees chair Dr. Hetal Gore. She's a gynecologist in New York, New Jersey area, and she's going to talk about cancer screening in women, and that's another very important topic. We, as you know, API launched a HPV vaccination drive both in this country and in India, and we started that during the Global Health Summit. So this is another interesting thing which I'm waiting to hear, and then we want to hear about from Dr. Krishna Swami about the role of GLP-1, and I'm really looking forward to what differences there are in the women's health. As Tarak said, our convention is coming up on July 4th weekend, 2nd to 5th of July in Tampa, Florida. We have a very strong program, and the website is ready. It's very easy, apiconvention.org. ORG, one word. And if you can go there, see that program is still not finalized, so it's going to come up, but you can get a preview of that. And registration should open within this week. So please look out for the registration. There is first come, first serve according to table seating. So you want to be if you are planning to come, please be one of the first people to register, because that makes the table seating will be based on one of the criteria would be when you registered. So I welcome everybody to Tampa, Florida, and over to Kavita. Please carry on, and I'll just sit back and watch this wonderful CME.
Thank you, Dr. Amit Chakravarti. Good afternoon, everyone. I am Dr. Kavita Jyotula, board certified in internal medicine, currently working as a hospitalist in Louisville, Kentucky. I am the current chair of AAPI Women's Physician Forum. I'm very excited to welcome you all to our first AAPI Women Physician CME for this year. I would like to sincerely thank our AAPI President, Dr. Amit Chakravarti, and our CME Chair, Dr. Tarak Vasavada, for giving me this opportunity and for their continued support in organizing educational programs like this. Today, we will have 3 speakers. After each presentation, we will have few minutes for question and answers. Please type your questions in the chat box so I can read them to the speakers. You will get CME credit in 7 to 10 days. You will get an email regarding it. You need to answer a few questions to get your credits. Without further ado, let me start the CME session. It is my pleasure to introduce our first speaker, Dr. Anjali Gulati, MD, FACC. Dr. Gulati began her medical journey at Gandhi Medical College in Bhopal and went on to complete her residency in internal medicine at Albert Einstein College of Medicine in New York. She completed her fellowship in cardiovascular medicine at Stanford University. Currently, she works at her private practice in San Jose, California, bringing world-class cardiac care to her patients. Please join me in welcoming Dr. Anjali Gulati.
Thank you, Dr. Jyotula. Congratulations on running an excellent year for Women's Forum and AAPI, and look forward to the rest of the year. Thank you, Dr. Tarak Vasavada, CME Chair, for giving me the opportunity to speak here. And thank you, Dr. Amit Chakravarti, for a wonderful introduction. Good morning to all of you, and welcome. If I can share my slides. Can you see my slides? Can you see?
Not yet.
It's sharing. How about now?
Not yet. Yeah, I can see it.
Okay, perfect. So I'll start this now. Okay, right. Let me just turn my phone off. Okay. Good morning, everybody. It's my honor to speak on women and heart disease. Let me turn my captions off there. So, women and heart disease, what are our learning objectives today? Learn that it is a leading cause of death in women. Identify gender-based risk factors in women. Recognize symptoms of presentation with heart disease. And here we are going to dispel some myths that Dr. Chakravarti just mentioned. Learn about gender-based bias in treatment, whether it's drug treatment or device treatment. Learn about lifestyle modifications for prevention of disease. Learn to be your own advocate for prevention and treatment. Now, all my slides are very colored. My disclosure is in black and white. I have no financial relationships and no financial conflict. Okay, all of us know about breast cancer. It is a devastating disease, and women are affected. I mean, men, very small percent, but it's essentially considered a woman's disease. And a lot of women are affected by it and a lot die. So we have all done walkathons. We have supported our patients and friends with breast cancer. It's a big deal. What we don't realize, what the normal women diaspora doesn't realize, that there are deaths by breast cancer. And if you look at this US mortality data from 2022, look at the right bottom over here. Breast cancer is over here, and heart disease, cardiovascular deaths are up here. And there's chronic lung disease, there's lung cancer. The total number of deaths that year was 446,912, which is 31% of the US women's population at that time. If you look at the deaths, cardiovascular deaths combined all the other cancers, compared to that, cardiovascular disease kills more women. What is the magnitude of the problem? So if you look at the magnitude of the problem, 1 in 8 women will get breast cancer. 1 in 43 women will die of breast cancer. Prevalence is about 4 million women in the United States. Breast cancer deaths, 43,250. This is the 2020 data. Heart disease statistics, 1 in 3 women will die of some form of cardiovascular disease. Prevalence in the United States that year was 63 million women, and cardiovascular deaths 446,912. If you divide that by every day and by minutes and seconds, the statistics are alarming. 1 in 80 seconds, some woman is dying of heart disease annually. Those are alarming data. So heart disease is the number one leading cause, number one killer of women. Now, what is the bigger problem? It's a big problem that they are dying. A big problem that we face is the lack of awareness. When we hear breast cancer, yes, it can happen to women. When you hear heart disease, the attitude of women is heart disease? Me? Not breast cancer? Heart disease is the killer? Well, less than 50% of women, when polled, recognized that the leading cause of death in women is heart disease. And what's worse is that this awareness has been declining from 65% in 2009 to 44% in 2019. Despite the age of internet and information, women still don't know. Their awareness has been decreasing. But I bet you if they poll them again, it will be higher since 2019. Now, what are the risk factors for heart disease in women? The traditional risk factors, the ones listed over here, apply to men and to women. Family history of heart disease, high blood pressure, high cholesterol, diabetes, smoking, physical inactivity, overweight, unhealthy diet, and stress. All of these are traditional risk factors in men and in women. It applies to both the sexes. What's interesting is that in women with diabetes, I'm just going to move my slide a little. Women with diabetes have higher CVD risk than men. So diabetes is a risk in both, but women have more. Hypertension. The curve for hypertension in women is different. After menopause, there's a sudden rise, and you have to be aware of it and treat it. Lipoprotein A is in men and in women. It is stable in men all their life. You test it once, it pretty much stays stable. In women around menopause, it actually rises, and it's a very atherogenic particle with a high risk of heart disease. Smoking, same number of cigarettes cause vascular injury in women than in men. Gender-based risk enhancers. Now, women have some specific gender-based enhancers like autoimmune disorders specific to women. Women have higher rates of systemic lupus erythematosus. They have higher rates of rheumatoid arthritis, which puts them at risk for coronary artery disease. Younger women risk enhancers. Menarche, early menarche less than 12 years of age is a risk factor. Polycystic ovarian disease is a risk. Smoking, diabetes, we went through it. Use of oral contraceptives and obesity. And this is rising. And as it rises, the risk of CVD increases in women. In menopause, everybody knows that there is a sharp increase in cardiovascular disease risk due to hormonal and vascular changes in women. Now, gender-based and risk enhancers in women related to pregnancy. Now, reproductive years, women with who have hypertension, diabetes have higher risk, increased rates of hypertensive and placental disorders. Let's go to this pregnancy area. These are really alarming. And actually, I have to close this here. Okay. Pregnancy, over 1/3 of maternal deaths. Look at this pregnant lady. Over 1/3 of maternal deaths in the US are from CVD. And if you look up here, it's the number one killer of new moms. That's really disturbing statistics. Adverse pregnancy outcomes. If a lady has gestational diabetes, gestational hypertension, preeclampsia, or low preterm birth weight, this puts them at a higher risk for developing cardiovascular disease later in life. And this is important when we talk about prevention. Symptoms. So here is the symptom. This is something that is very dear to my heart. For years, I have been saying, and now finally data has come out, so it's very good. Everybody keeps saying women have atypical symptoms, women have atypical symptoms. Actually, no. Contrary to popular belief, most women with acute coronary syndrome present with typical chest pain, believe it or not. In the past, the data was 30 to 40% present with chest pain, and the rest will have atypical symptoms. Now the data is very clear with the AAPI study, and I will show it to you in a second. 74 to 92% of women presenting with acute coronary syndrome, myocardial infarction, or unstable angina have used the word chest pain. We used to say symptoms typical versus atypical. No, you have to pay attention to what a woman is saying. This is the AAPI study, and I love it. And this is the age of information. They took an AI bot and they let it record all the conversation between the patient and the doctor. And what the bot found is that the woman was saying chest pain in her description. However, look down here over on the left bottom, chest pain. Wait, did you hear that? And the doctor is hearing stress, anxiety, gas. It's a computer that finally looked and said, oh my God, woman has said chest pain so many times in her history. She has said chest pain, so let's check her heart. And in this study, almost 89 to 92% people, women, had said chest pain when they presented. So women can present with typical chest pain, classic Levine sign, just as much as men can present. The interesting thing is that the women present with more accompanying symptoms. So fatigue, shortness of breath, indigestion, dizziness, pain in the lower chest or upper abdomen, or back pain or extreme fatigue. Don't forget, even men can present with these symptoms. So it is very important to know that women can have typical and they will have 2 or 3 accompanying symptoms. So it should be easier to diagnose them, but somehow it has not been the case, and that's because of the gender bias. What is difference between the heart disease in women and men? There are a few gender-based differences. They can have obstructive coronary artery disease, but myocardial infarction, MINOCA, myocardial infarction with non-obstructive coronary artery and ischemia with non-obstructive coronary artery disease is very common in women. They have more coronary microvascular dysfunction. They have a higher risk of ACS, MI, and stroke, and a higher risk of HFpEF, heart failure with preserved ejection fraction. Takasobu's disease, stress cardiomyopathy, 90% of women with this are women, 90% of patients are women, and 10% of all acute chest pain in postmenopausal women is Takasobu's. 5% in hospital mortality, 20% have persistent LV dysfunction, 20% have recurrent Takasobus, there's no proven treatment, and there's no prevention for recurrence. So there is a huge gender bias in diagnosis and treatment. So let's look at what should happen and what is happening. So if you look here, if a woman presents with chest pain, it should be rapid triage, just like a man. Actually, a woman has to wait 10 minutes or longer. They should have an immediate ECG. A woman is less likely to receive an ECG. They should have continuous monitoring. They're less likely to be monitored. Early on, cardiologists should be involved. They are less likely to see a cardiologist. They should get admitted when appropriate. Well, guess what? Hospitalization is less. They are less likely to be admitted despite the fact that they presented with chest pain. And women have worse outcomes. Women less than 55 years have even worse outcomes. Higher rehospitalization, higher 30-day mortality after STEMI, and higher risk of heart failure. Less use of guideline-directed medical therapy. It is unbelievable that women have low high-intensity statin use, low aspirin and antiplatelet use, low beta blocker prescription, lower angiography and revascularization rates, and lower use of mechanical circulatory support. Gender disparity, we just went through this. Oh yeah, this also has that lower door to balloon time, longer door to balloon time, less likely to undergo cath and PCI, lower likelihood of receiving thrombotics and TNK, let's just put it TPA, thrombotics, and longer door to needle time, and they have more admissions. All this is very disturbing. Not only in recognition or treatment, there is also a huge gender bias. Can you hear me?
Yeah, I can hear you.
Okay. There's also a huge gender bias in device use. Look at this. Transcutaneous aortic valve replacement has shown superior clinical outcomes in women, but it lags in referrals. Atrial fibrillation, women are more symptomatic. However, they are less likely to be referred for ablations or anticoagulations. The ICD and CRTs have been proven to be very beneficial in women, but guess what? Again, lower referral rates. In LVADs, only 25% of recipients are women, and in transplants, cardiac transplant, only 25% recipients are women. The key takeaway is clinical evidence supports treatment for women. However, access is not equitable. This is a busy slide, but this is important to know. Okay, gender bias in research trials. In 1977, FDA basically said women should not be included in trials because of the thalidomide drug disaster. And that actually affected, because men and women metabolize medicines differently. Men and women are different. So all the studies were done in men, and it was just by extension that women were treated. And it's interesting because a lot of drugs, I don't remember the exact statistics, which were withdrawn, were actually because women have more side effects. And of course, they'll have more side effects because they were not included in trials. Fortunately, in 1993, NIH Revitalization Act was passed, and it was deemed that women would be included in research. And in 2014, NIH requirement came because earlier they used to use only male cell lines and male mice in research. NIH said even female animals and cell lines should be used in preclinical research. So it is a little better now, but nowhere close to where it should be. Okay, now treatment part. What can we do to treat? Let's go over it very quickly because everybody knows about this. Let's talk about modifiable risk factors. Hypertension, you can modify. Now, target by AHA is less than 130/80. And then all this, the one I'll go over here is normally first line agents for everybody with blood pressure is ACE inhibitors or ARBs. However, in women of childbearing age, we should avoid these because of the teratogenic effects. Okay, what happened here? Sorry, I clicked on something wrong. Hang on a second. Okay, so hypertension in pregnancy, DASH diet, exercise, healthy weight management, blood pressure checks, manage comorbidities, labetalol, nifedipine, methyl dopa, okay, ACE inhibitors and ARBs must be avoided. Diabetes, I will let the next speaker talk about it. However, you should do, again, DASH diet adapted to diabetics, exercise, health, weight management, regular checkups, comorbidities, stop smoking, metformin, GLP-1 receptor agonists, SGLT2 inhibitors, and insulin. Lipid. Everybody knows about lipids, so I will not spend too much time. However, first line is not medicine. First line is that you should exercise. Women have additional benefits, healthy weight, minimize alcohol intake, smoking cessation, treat diabetes and hypertension. First line, of course, is statins to reduce the LDL-C by 30 to 40%. It reduces plaque inflammation and stabilizes plaques. Contraindications. Statins are contraindicated during pregnancy and breastfeeding. The rest I can take questions if you like. I love this. Exercise in women. I will take a minute over this. There are clear mortality benefits of exercise. Men, if they walk 300 minutes per week of moderate activity, have benefit in prevention. Women achieve the same benefit with actually it's 150, it's not 140, 150 minutes per week. And women gain more mortality benefit per minute of exercise than men. As far as resistance training is concerned, men can do 3 sessions a week. Women will get the same benefit by doing 1 session a week and get similar mortality benefit. And women will gain even more benefits by doing 2 sessions a week. So exercise really changes a lot. Okay, so what's the bottom line? Lifestyle modification. Eat well, watch your diet. Exercise, we just went over it. Sleep well, at least 6 to 8 hours. 8 hours is very good. Of uninterrupted sleep decreases your risk of having adverse effects from CVD. Quit smoking. This is one sentence I love to say. In the 50s and 60s, there used to be ads where there would be a woman holding a cigarette, and the ad caption was, "You've come a long way, baby." Now I'm going to say, quit smoking, you've come a long way, baby. Reduce stress, easier said than done. But if you do the above things, sleep well, eat well, exercise, and quit smoking, it actually decreases your stress. The endorphins in exercise definitely reduces your stress. Along with these lifestyle modifications, please get medical help. Because if you have things like hypertension, diabetes, lipids, you can treat them. Okay, so in summary, it's a leading cause of death. There is a huge lack of awareness. In this information age, it is getting better. Still, there is a huge lack of awareness. Understand risk factors. We went over the risk factors. Very important to know the non-modifiable risk factor is your age. You can't modify your age. The non-modifiable risk factor is your family history. You can't change your family, but you can change the modifiable risk factors, and we went over them. Stress, sedentary lifestyle, eating habits, sleep, exercise, quit smoking, treat diabetes, treat hypertension, treat lipids. And gender disparity in treatment modalities. So one of the things that I always keep saying is just remember, women can say chest pain, and if they say chest pain, please take it seriously. And by the way, it's not necessarily chest pain. It can be chest pain, chest discomfort, chest pressure, chest tightness, something not right in my chest. Chest discomfort, have all your alarms up. And so in recognition, end gender disparity. In treatment, we need to end gender disparity. In referral for devices, for subspecialties, electrophysiology, for congestive heart failure, to a heart failure specialist, to an EP person, to an interventional cardiologist, whatever referrals, they should be done. Get medical help, quick access to guideline-directed medical therapy. There should be, it's very clearly written. The guidelines are very clearly written. They should get it. Include women in clinical trials. It is happening ever so slowly. It needs to be on a bigger scale. And then, of course, population-specific public strategies, which come from public policies where they tailor prevention strategies for pregnant women, postmenopausal, that there's a type of postmenopausal women, and they should have community programs and preventive screenings. I heard a talk once where they were recommending that postmenopausally, if you remember the slide where the women had with the pregnant lady, the menarche and the postmenopausal, and the lady with the pregnancy-associated adverse outcomes, Those ladies at 6 weeks postpartum, they go and visit their OBGYN. Well, at that point, they should visit their primary care and discuss their cardiac risk factors and start talking about prevention strategies. So, improving early recognition and timely medical intervention will save lives. So, to all the sisterhood of Women's Forum over here, starting from Dr. Kavita Jyotila, take care of your heart. Thank you.
Thank you, Dr. Gulati. Excellent presentation. I really like your colorful slides. It's a very important topic, as you said, most neglected topic in women. Let's start our questions quickly. Somebody's asking, would like to hear need of LPA testing, lipoprotein A, small a.
Okay, I'm so glad. I was going to include it in my slide, but because of the time constraints, I had left it out. But I'm glad somebody asked because LP little a buzz is all over the map. So can you all see my slide?
Yeah.
Okay, so LP little a is a protein. The normal level should be 50 milligrams per deciliter. Anything above it is higher, or 125 nanomoles per liter. This is genetic. It's a genetic risk that's independent of all other lipid particles. 1 in 5 people in the USA have high LP little a, and this includes the Indian diaspora apparently. 63 million people in the United States have high LPA. This causes high prevalence of heart disease in families, and diabetes and chronic kidney disease and postmenopausal women have a higher level. Diabetics and CKD patients have higher LPA levels, and postmenopausal women actually have a rise. And it's high in South Asians and Africans. And here is the particle. Now, it's autosomal dominant inheritance, untouched by lifestyle modifications that govern hypertension or obesity. Very important to understand that you can change everything in your lifestyle or treat hypertension or obesity, but the LP little a level does not change. Now there are phase 3 studies in Europe, and hopefully we'll get them in the United States soon, that are using siRNA and ASO, it's antisense oligonucleotide therapies, and this is showing that it's showing very, very good, promising results. So hopefully it will come down. Right now they have regular dosing in their phase 3, but they're hoping that the dosing will become monthly or 6 monthly and it will get better. So this is good because once we are able to use that ASO and RNA therapies, we can tell the patients that their family history is no longer their destiny, because now we are changing it at the RNA and the oligonucleotide level. It's very important. The takeaway point is LP little a, it's genetic, autosomal dominant. Up till now, there was no treatment, and none of the lifestyle modifications was changing it. However, it's a very pro-atherogenic particle which buries under the intima and causes the foam cell formation to increase. It's very pro-inflammatory, high load of oxidized phospholipids, and it triggers vascular inflammation and accelerates calcific aortic valve disease also. That's very, very interesting. And it's prothrombotic and antifibrinolytic because of its structure similar to plasminogen. So up till now, no treatment. In the future, hopefully in our lifetime, we will see treatment for it.
Okay. The next question is, would you suggest patients who does not respond to GI symptoms like GERD or moderate hiatal hernia to get a stress test?
Oh, absolutely. If a person is presenting with symptoms of indigestion, very interesting. The Italians call indigestion agita. And in the Bronx, when I was doing my residency, there were so many people that came with agita, agita. They used to say agita. It took me a while to figure out. Actually, figured it out pretty quickly when I saw the first case of heart attack with agita. Lot of patients present with gastric symptoms, and this is in men and in women. If a patient is complaining of acidity, indigestion, some of them will say, there's a burp stuck in my esophagus, in my food pipe. Some people will say, I swallowed a frog. I have this lump in my chest. Pure reflux, acidity, any of those signs should be taken seriously, and they should talk to their doctor and get evaluated for possible underlying ischemia. Absolutely. After chest pain, the most common symptoms are indigestion, gastric related, shortness of breath, fatigue. Those are the big symptoms.
Nice.
What's the worst case scenario? You get your stress test, it's normal. Well, then you go get antacids.
Sure.
One of the cases that they taught us in our residency when I first started in my first year, the first thing, one of the cases they told us was this cardiologist in Peninsula here in the San Francisco Bay Area. The gentleman, he was a cardiologist, extremely well known. He was found dead in his closet, clutching a bottle of Tums. So that should be taken very seriously. He was in denial. So yes, the answer is yes, short answer.
Next question is, during exercise, what is the current target heart rate, especially for seniors and young adults? Also similar related regarding exercise, what is the type and duration of exercise in postmenopausal women?
Okay. So this is a very good question. I don't have all the statistics, but I will try to answer it. In men or in general, I went through the slide and I can go back to it. Let me see if I can bring it up. Let me see. Give me 1 second. Exercise is one of the most crucial things that changes things. So if you look at it, moderate intensity, 300 minutes a week. High intensity is half of that. I think it's half, I think it's 75 minutes. High intensity is 75 minutes a week for men. For women, they achieve more benefit by the same exercise or even less exercise. So that 140 is a typo. It's actually 150 minutes. And in resistance training, we went over this data. Now, what should be the target heart rate? When we calculate maximum predicted heart rate in patients during a stress test, the formula that we use is 220 minus age. And that is your 100% maximum predicted heart rate. So let's say somebody is 20 years old, just for mathematics' sake, their maximal predicted heart rate will be 200. Somebody is 40 years old, their maximum predicted rate will be 180. That's the maximum predicted heart rate. When we do a stress test, we try to target at least 85% of the maximum predicted heart rate. That's in the Bruce protocol. Now there's a new study, and I'm sorry I don't have the data. I can find it and give it to you all before the end of today. There is a paper that I read about women. We should actually recalculate their maximum predicted heart rate because women are not smaller men. Women are different. Women are women. So they are saying now that we should actually recalibrate all the smart devices and all the smart applications, that the 220 minus age is for men, and for women it should be 208 minus age. So there is new data about it. It hasn't been done. I'm hoping to see it in the future, where all the devices will now have a new target for women's heart rate. So that will be 208 minus age.
Okay.
Does that answer?
Yes, yes.
Thank you.
There are a lot of questions regarding lipoprotein small a. They're asking whether other lab tests like lipoprotein B, apolipoprotein B, and homocysteine or any other tests can be done, especially if the lipid profile is normal? What would you suggest before going and seeing a cardiologist?
Okay, yeah, we see this all the time, and especially with our Indians, they go get every panel done. So I always tell my patients, get the traditional risk factors addressed first. Now, if you have a very high family history of premature coronary artery disease, by all means, you need extra. If you're at a higher risk for family reasons, or if you have phenomenally high LDL, which is not coming down, or if you have some special risk factors which we went through, check your LP little a. But you don't have to keep checking your LP little a all the time, because you check it once. In men, it's not going to change over your lifetime. You don't need to have your blood drawn every few months to check your LP little a. Check it once, know your risk factor. Then, if you know LP little a is high, and you also know that at this point of time, there is no treatment for LP little a, and you know that it's putting you at a higher atherogenic risk, then work on your traditional risk factors. But you don't need to keep repeating LP little a. Homocysteine, of course, is also associated with high risk of coronary cardiovascular disease. However, you don't need to keep checking it. Check your homocysteine, take folic acid, B12, and go from there. Check it once. And actually, there's a panel of almost 100 different markers that predict coronary artery disease. And if you want, you can go crazy with that, or just deal with your traditional risk factors, work close with your doctor and your cardiologist. For people with high LP little a and extremely high familial hypercholesterolemia, hypertriglyceridemia, for familial issues, they should actually consider doing a cardiac CT calcium score, because that also helps with management of the patient in planning what to do in future with the LDL and how aggressive they need to be. There used to be a test, and it's still there, where you do particle size for LDL and HDL, because the dense particle is more atherogenic than the light fluffy one. So you can always get that. If you have extremely high cholesterol, just traditional lipid panels, get the specialized LDL and HDL particle test done. It is very helpful.
Okay. Thank you, Dr. Gulati. Because of the timing, we're going to go to the next speaker. Thank you so much for your time today.
Thank you, everybody.
Our next speaker is Dr. Hetal Gaur. Dr. Hetal, please start sharing your slides while I introduce you.
Yes,
Dr.
they are.
Hetal Gaur is a board-certified OBGYN practicing in Englewood, New Jersey. Dr. Gaur did her medical and OBGYN training from India, UK, and USA. She won multiple awards as a top doctor, top 10 GYN surgeon award, Compassionate Doctor Award, Patient's Choice Award, International Woman Award for Balancing Career and Family, International Academy Award 2017, Rising Star Award 2016, Nari Udyami Award 2018, Top 500 Gujarati Worldwide, CAIT Award for Women Entrepreneurship in 2021. Dr. Gaur has authored multiple articles on WebMD and peer-reviewed journals. She was instrumental in starting free health fairs in Bergen County and sits on multiple nonprofit and charitable organizations. Dr. Hetal Gaur is medical director and owner of Better You Medical Spa, CEO of Health Media LLC, and medical director of Women's Own OBGYN. She sits on New Jersey Statewide Advisory Commission on Minority and Multicultural Health. She had her own medical talk show, political radio show, podcast, and YouTube channel. She is the current president founder of Bergen Indian Medical Association, president founder of US chapter of Federation of OBGYN Society of India, and current chairwoman of Board of Trustees of AAPI. Please join me in welcoming Dr. Hetal Gaur. Dr. Gaur?
Hi, everybody. Thank you so much, Kavita, for that wonderful introduction. Thank you, Dr. Amit Chakravarti, President, Dr. Tarak Vasavada, the CME chairperson, and my esteemed colleagues who who did and who's going to do presentation. And happy Women's Month to everybody. And thank you all the participant, because it's very difficult to take so much time out of a Sunday to listen to this. So without further ado, I'm going to go and talk about cancer screening in women. And this is particular to United States because screening criteria are different for country. And this is, I put the year because criteria can change. So this is valid right now for so what are the learning objectives? So the objective of this talk is to learn about screening for cancer, burden of cancer diseases in women, importance of screening for women cancer. What are the
Dr.
different...
Gaur, please share your slides.
Are they not coming, dear? Sorry. Let me go back. I thought I was sharing.
I see it.
I'm sorry. I thought I was sharing. I'm so sorry.
It's okay. Looks good.
Yeah?
Yeah.
All right. So is everybody okay? Can everybody see? Okay. So yeah, so the learning objectives, we discussed about it. Now, what is the burden of women cancer in the United States? So estimated number of new cases, which are projected for this year, is almost 1 million, right? So it's a huge staggering number with 298 projected deaths that will be because of that. It's always dominated by breast cancer and followed by lung and colorectal cancer. So the colorectal and lung cancers are also another important stuff in women's cancer. We don't talk much about it. Most women cancer, we talk about breast and cervical and uterine. Those are important things. But also, we have to also remember that the lung colorectal cancer, which goes in both the genders, are also important cancers in women. So the lung cancer estimated cases are 118,000 new cases this year will be projected, and the death will be projected deaths are 61,000, colorectal 74,000, and 25,000 approximately deaths. Uterine cancer is 68,000 and 14,000 projected deaths. Ovarian cancer 21,000, 12,000 projected deaths, and so on and so forth. Of course, there are other cancers that are also important, like urinary bladder, kidney, thyroid, lymphoma, leukemia, melanoma, oral pharynx, and cases. So just to give an outline in different states, right, how many cases we are seeing. So California, the breast cancer number of cases, the new cases are 34,000, approximately. Cervical is 1,000, uterine is around 7,000. Compare that to Texas, the breast cancer new cases are 24,000, cervical 1,470, uterine 5,260. In New York, the breast cancer is 19,000 new cases, cervical 770, uterine 4,000. Florida is 24,000 for breast, cervical for 1,200, uterine for 5,490. So just to give an idea, these are the 4 states with the highest numbers. As you can see, the trends that has happened. So the trend, if you see overall, the number of, we have won this battle since 1960s. If you see, the risk for uterine cancer, stomach cancer came down since 65 onwards. The risk for lung cancer started actually going up, and the number of cancer-related death due to lung and bronchus started going up. Finally, the trends in, we are seeing it is going down, as we can see. So this is the trend, right? You can see the lung and bronchus went up, but now finally going down. Finally, we have got the colon cancer and breast cancer risk, which is going below. These are the sites compared to men and women. What are the estimated new cases and estimated deaths? We can see the numbers. yes, it's led by breast, followed by lung and bronchus in cases of new cases. But in death, the lung and bronchus takes over. So the mortality from the breast is lower than the lung, even though the number of cases, new cases in breast are higher. So that's now cigarette smoking is not only causes lung, bronchus, and trachea and larynx, but if you go down, especially in the woman, it's associated with cervical cancer risk. And that's something that is very important in cervical cancer. And when you are, we always talk about HPV vaccination, but smoking, cigarette smoking is also increases the risk for cervical cancer. Obesity is another risk factor that increases the risk for cancer. And definitely in women, like we see, the uterine cancer is related to the obesity, gallbladder, esophagus, etc., etc. So that's also a very important factor to keep in mind when we are talking about cancer. If you see the burden of this modifiable risk factor, the tobacco user is globally an issue, followed by alcohol and excess body weight. So U.S. Preventive Services Task Force gives a rating for any screening. If there is a strong evidence, there is a weak evidence. D means there's no evidence to do screening. I means that it's evidence is there, but it's not as strong. So it's an intermediate screening numbers that the guideline has given us. So what's a screening, right? What is screening? So cancer screening, the aim is to detect cancer before the symptoms appear. There are various ways to do it. You can either do a blood test, you can do urine test, you can do cytology, medical imaging. Why do it, right? What is the purpose? So purpose is that if we can prevent cancer, so like in cervical cancer, if we find high risk changes in the cytology, we can actually prevent cancer in those cases if we do proper treatment. So that's the idea of screening, either prevention, early detection, subsequent treatment, and benefits outweighs the risks. It should be an important health problem that in frequency as well as in severity. The natural history of the disease gives us that window of opportunity for early detection. Effective treatment should be available and favorably alters the natural history of the disease. Treatment should be more effective if initiated in early rather than later stage. Suitable screening tests should be available and appropriate screening strategy for the targeted. So this is why screening can be done and what is this whole idea about screening. So ideal screening should be relatively cheaper, sensitive, as well as specific. It should be accessible, safer, and acceptable. Of course, there are biases in the lead time, length of the bias, like if it's a slow growing, less aggressive tumor versus fast growing, selection biases. So there are certain pitfalls of screening as well. What are the pitfalls of falsely positive test that gives anxiety and unnecessary invasive diagnostic testing? If those screening tests that have high false positive test, overdiagnosis, sometimes diagnosing a condition which might not be so clinically relevant, or falsely negative. So these are some of the pitfalls of screening. So going to the breast cancer screening, what is advised between age 20 to 40 is just clinical breast exam every 1 to 3 years. In more than 40 years, annual clinical breast exam along with annual screening mammogram and mammogram. Why do mammogram? Because it detects a disease 2 years before clinically palpable. Yes, the yearly screening is thought to be beneficial, and I'll go through the guidelines and what are the newer guidelines. So these are the NCCN, the National Comprehensive Cancer Network guidelines, that there is no upper limit, right? A lot of times I get patients who are in their late 70s, 80s, and they say, should I continue screening? So like in the late 80s, I would say, yeah, but also you have to see at how the young that person is. I have seen 80 years old who are like really, really active as good. And then you have late 80s who are not so good. So you have to kind of figure out, like, is the screening going to add to their life? Or even if there's a cancer, if the person is going to die because of heart disease, I'm not going to push that lady to go for her screening. So There's no upper limit. A clinician can decide as it is. Digital mammography definitely has benefit to young women and or women with dense breasts. Usually they are added with ultrasonogram to kind of detect cancer, and false positive results are reduced when you add digital mammography along with the breast ultrasounds. If when and how do you do MRI screening? Is it as an adjunct to the mammogram? So the evidence-based recommendation is a person a carrier for BRCA mutation, or they have a first-degree relative of BRCA carrier, but they are not tested, or their lifetime risk is 20% or more, then they will benefit from MRI. Of course, we all know about the testing for the hereditary breast and ovarian cancer syndrome, and these are the NCCN criteria. So if there is an individual with a known BRCA mutation, then of course we'll be treating and doing a different way of testing, as we mentioned about the mammogram along with breast MRI. They have a personal history of breast cancer, but they are diagnosed either at age less than 45, or they were diagnosed at age less than 50, but they have a close relative. They have two breast primaries, but the first breast cancer was diagnosed at age earlier than 50. They have a male relative with breast cancer, personal history of either ovarian, fallopian tube, or peritoneal cancer. Or they have a individual with ethnicity like Ashkenazi, etc. Apart from that individual breast cancer history, if there is also a personal history of primary epithelial ovarian cancer, a personal history for male cancer, or family history of first or second degree with above criteria, or they have a third degree, but one has a primary fallopian tube and breast cancer less than 50. So what are the women at risk for breast cancer when the risk is increased? So there's something called as scale model. When there's 5-time risk of 1.7%, then you start screening them at age 35, and then you do clinical breast exam at 6 to 12 month interval and added by annual mammogram. If there is a 20% lifetime risk, then you'll start them at screening at age 30, not at 35. Clinical breast exam every 6 to 12 months, annual mammogram along with that. And if they are BRCA carrier, then you start screening actually at 25 years of age, and then you do clinical breast exam at 6 to 12, and then you'll add MRI along with that annual mammogram. A lot of times we do like a baseline mammogram at age 35, even if they are normal risk people, because then you know what the breasts look like at age 35. And then when they start either, now we start at age 40, and annual or biannual exams are done, and we kind of pick up, changes from their previous mammogram, and you can compare. So this is, most people know how the mammograms are done, and it's a little painful because the breast is squashed, so it becomes like a flatter surface. And as you can see on the right, that's how the cancer looks. Sometimes they have to change the positions. So for our male colleagues, that's how it's done. We do ask patients to do their breast exams, and this is how they are doing it. I usually tell them to do it like in the bathroom, just after the period. For postmenopausal women, I tell them to do it either the first Sunday, or they can fix a day in a month. So that way there is some sort of routine that they don't forget then to do an exam. If there's a palpable mass, what do you do? If they are less than age 30, they get ultrasound done first. And then if depending upon the BI-RAD classification, either they go for a tissue exam, or we just follow up. If they have benign lesion, either fibroadenoma, etc., and they can be either monitored or surgically taken care of. If they are more than 30 years old, palpable mass, first they'll go for a mammogram, maybe ultrasound, and depending upon where they follow in the BI-RAD. Cervical cancer screening, we talk about this in OBGYN circle. It keeps changing time to time, and we've gone back and forth with this. But the consensus is age 21 to age 29, you do pap smear every 3 yearly. It's only a pap smear. We don't do co-testing for less than 30 years because There will be HPV which might be cleared off as they grow older. So in that age group, there is no point of doing, and that's very important because I get referral from patients who have had pap smears by either their primary care or family practitioners, and they add HPV into that. That has led to unnecessary biopsies and colposcopy. So it is recommended that age 21 to 29, just do the pap smear. There is no need for HPV. From age 30 to 65, 65 is the upper limit, but I've seen in certain cases where there is a change in the partner, the risk actually keeps going up. So sometimes if the insurance allows, we don't stop it at age 65 because either because of divorce or separation or the spouse has died, people have had new partners even at age 70, etc. And a lot of cases actually then show up late. So again, it comes to clinical decision when you stop anything. But between 30 and 65, pap smear is done every 3 years. You can do co-testing. So you do pap smear along with high-risk HPV, then you can do it every 5 years. Or you can just do HPV high risk every 5 years. So these are the criteria that have been given, but it always comes down to your individual, clinical risk factors that you should keep in mind. If somebody has a new partner or multiple partners, sometimes waiting for 5 years is not a good idea. So you always have to individualize when and how you do it. In the latest things, I'll talk about what is something new that has come up. It's called home testing now, that one can do just the HPV testing. And I always tell people that when women come for annual exam, pap smear is not the only thing we do because clinical breast exam is very important. So annual exams are still important, even if we might not do a pap smear. So there is little difference that one has to understand. This is how the pap smear is done for non-gynecologist or a non-family practitioner. The speculum is done. The cytology is collected from the external os. You try to go as much inside, and that's why it's tapered like that. So you try to get as many cells even from the cervical canal. Same thing that we discuss about co-testing and when do we start. This is just like a guideline. So when is a atypical squamous cell of unknown significance, that's called ASCUS. You can either repeat it if there are young people, if there is no HPV testing, then you can repeat it in 6 months, just the pap smear, or you can add the HPV testing, and if HPV is positive, then you can either send them to for colposcopy. So colposcopy is recommended for low-grade changes, high-grade changes, ASCUS with high-grade changes, which is SCC-H. That's the atypical squamous cell, but some cells look like high-risk changes. So those are ASCUS-H that they need immediate colposcopy. If it's aglandular atypical cells in it, which means that there are certain cells which are glandular, they are not just squamous. That means that some of the cells came from the uterine lining. And so those cases, we do colposcopy along with endometrial biopsy because this might be endometrial cancer that is being picked up on the pap smear. So for AGC, we require to do endometrial biopsy. Now, colposcopy, just in broad, to understand if there is a lesion, then you will definitely take a biopsy. We put aceto-white, so we see those lesions very prominently. If it's CIN1 and 2, you can either do cold knife cone biopsy or a leap. If it's a CIN3, you can either do cold knife cone biopsy, leap, or depending upon the changes or risk factors, one can even do just simple hysterectomy. If it's, of course, invasive cancer, then you will treat according to the staging, and atypical intraepithelial lesion, then you can just do cold knife cone biopsies. If the biopsy is negative or lesion is not seen, then you can either repeat the pap and the cytology or HPV testing at 6 months or 12 months. And if invasive, we'll treat accordingly. Ovarian cancer, it's something where it's not, we don't do screening for ovarian cancer for routine general population, but if they are high risk, then these are the suggested ovarian cancer screening. We have now what's called liquid biopsies when we derive this cells from the serum and plasma, and then there are biomarkers that we can look for. CA125, most of us know. There is MUC16 gene, that's like an antigen, tumor-associated antigen that can be done. Our transvaginal sonogram for any ovarian mass or tumors is what is recommended for those high-risk patients for ovarian cancer. Uterine screening cancer risk factors are nulliparous, somebody who's never had children, late menopause, that after age 52, obesity, as we discussed earlier, is a huge risk factor for uterine cancer, diabetes mellitus, unopposed estrogen therapy, which should not be done. A lot of women are taking hormone replacement, but I've seen some of the professionals, they don't give progesterone, they only give just estrogen. So those risk factors, the unopposed estrogen increases the lining, and it increases the chances of you getting or one getting uterine cancer because it's not opposed with the progesterone. So unopposed estrogen, if you have a uterus, is not the treatment. It should be hormone replacement should be done with estrogen and progesterone. Tamoxifen increases the risk. If routine transvaginal sonogram is not recommended unless and until they have some bleeding, then you will do transvaginal sonogram, and we'll come to that. How do we screen for uterine cancer? Atypical endometrial hyperplasia, if one has, then one should be screened. So screening is done with a transvaginal ultrasound. We are measuring the thickness of the lining of the uterus, and we also can pick up like polyps, etc. The cutoff for the lining is 4 millimeters. So when in transvaginal sonogram, if the lining of the endometrium is more than 4 millimeter, that's abnormal finding. There are other non-invasive testing, which is the transvaginal sonogram. However, the estimated sensitivity 20% lower in asymptomatic versus symptomatic patient that we discussed. So this is ultrasound picture of 3 different patients. So the first ultrasound picture here shows a polyp. This is a thickened endometrium in the middle picture, which is very homogeneous. So this is a sign of hyperplasia. And in the last one, you see it's very erratic, very thick, and that's endometrial cancer, which is, so first one was the polyp, other one was hyperplasia, and the heterogeneous thickened one is malignancy. Something called as pipelle biopsy. This is has changed the game for detecting endometrial cancer because this is an outpatient, very inexpensive way to diagnose it. There is no need for anesthesia, no operating room. Most of the time, I even do it without tenaculum, so it's very less painful. There's less amount of scraping, patient acceptance, and successful of obtaining the tissue sample is very good, more than 90% of the time. So as you can see in this picture, the small Pipelle is introduced inside through the os, especially if somebody is multiparous, has vaginal birth. It's really very easy to perform. We put it inside, and the inside tube is withdrawn while outside tube stays inside the cavity. That creates a negative suction, and it pulls in the cells. And cancer cells are less sticky, so those are the cells has very good pickup through that. There's something called as tower brush. It's a little painful to do it. The advantage of tower brush that it picks up more tissue compared to pipelle. It's painful. Hysteroscopy is when we look inside the lining of the uterus. Where when do we do this? We do it in the cases where there's some sort of stenosis, somebody who had C-section and are postmenopausal. It's very difficult to then get inside the lining. If the bleeding recurs after negative endometrial biopsy or multiple times, then you will want to look and make sure that you're not missing anything. And it can be like a polyp or something, which not always means it's cancer, but you will look inside with the hysteroscope and take care of the lesion that it is, or if the specimen is inadequate. This is how a hysteroscope is done. We also do it in outpatient office based with some sedation. These are very flexible hysteroscope we use. The one in OR are rigid ones. And as you can see, you can visualize the whole lining and pick up abnormal lesions. This is the slide showing vulvar cancer. We don't talk much about it, but it does exist. Usually, we've seen it in elderly women in usually 70 to 80 years. They are usually diagnosed late when there is a big lesion. That's when most women come. It's squamous cell most of the time. So to understand this, please, if anybody at a later age has chronic pruritus of the vulva, and it's not, say, yeast or anything, one must look in with the colposcope and kind of evaluate those lesions. If they are HPV related, like diseases like warts and all, sometimes one has to be suspicious about cancer, and pigmented hyperkeratotic area needs to be biopsied. So we biopsy them, we do colposcopy where we can see the lesion enlarge, we put acetic acid and the acetobite changes, and then you take a biopsy. Also, if they have lichen sclerosis, they are at higher risk, HPV, genital disease, as we discussed, and most of the time we refer to GYN oncologists for Paget's melanoma and VIN. This is VIN3 lesions that can be seen, and this is for the vaginal lesions. We do vaginoscope, and as you can see, there are acetobite areas. This is early stage squamous cell, and it just looks like somebody scratched it and stuff. So a high suspicious, you should keep it if there is a chronic pruritus or they have a history of HPV or HPV related changes in the cervical cancer. In cervical pap smear. So this is in nutshell about cervical cancer, what can be done, vulvar cancer, endometrial cancer. Going to lung screening, I'll quickly talk about it. If what age, 50 to 80, are they smoker? Are they been how many packs of smoking? So bottom line, if there's a 20 pack year or greater history, then one should screen for lung cancer. And these are the NCCN guidelines about that. When do we CT should be offered for smoker or former smoker at age 55 to 74 with more than 30 years pack. They've changed the guidelines now to 20 pack a year. Colon cancer, which is another number 3 cancer for women. Screening modalities is colonoscopy either every 10 years or flexible sigmoidoscopy every 5 years or CT colonography every 5 years. There are other modalities, which is guaiac-based screening, immunochemical-based screening, and stool DNA test with high sensitivity. Genetic and colorectal cancer depends on the family history and the polyposis and stuff. With the patient with no familial mutation with history of 10 adenomatous polyps, and genetic testing should be done, and counseling is recommended for people with multiple polyps. 10-year is an interval that average risk patient one should get it. Shorter interval if if there is a higher risk or there were findings that required. Colonoscopy does come with limitation because it cannot detect all cancers and all polyps. It can be flexible sigmoidoscopy is another way of modality that can be done either by itself or along with the stool-based screenings. It requires no sedation, unlike colonoscopy, and no bowel prep. So it is only limited to the lower half of the colon. But if somebody cannot do bowel prep or this along so flexible sigmoidoscopy is a good way to then screen these people along with stool-based screening. If the lesions are more than 1 centimeter, they should be referred for colonoscopy. So this is just a slide showing how the lesion looks, and the whole colonoscopy, and sigmoid is just the lower descending part. Computed tomography colonography can be also done. This is like a virtual colonoscopy. It's non-invasive, doesn't require sedation, so some people like it to do that. Fecal-based testing, we know it's become really, a lot of my patients actually prefer to do fecal-based screening test because it's at home. It's easy to do it. There is no preparation required. There is one which is guaiac-based, so it's if detecting blood in your stool, and then there is immunochemical ones which detects through the hemoglobin with the inside the hemoglobin, that's the immunochemical one. Now we have the stool DNA one, which also detects, but it's not yet approved by FDA, but it's commercially available now. So what is the update in cancer screening? So these are the updated Health Resource Service HRSA. Now, what it's in short, what they are saying that one can do a mammogram, but if they need the added ultrasound or if they need any biopsy, this should be covered without any copays. So that's a new guideline for 2026 now that before it was just for mammogram screening. Now, along with mammogram, if they need added testing, that should be without any copays, right? So without any cost sharing. So that's the new guideline that they have to cover not only the mammogram, the referral, transportation, patient education, coaching should be covered by insurance without them paying any copay or deductible. Along with, in addition to the 2026 HRSA, what U.S. Preventive Task Force has added that risk reducing medication also should be covered when it's clinically needed. And 40 to 50 initially, the mammograms were not covered by insurance. Some insurance didn't cover it, but with HRSA guideline now they have to cover screening from 40. Either they can do annually depending upon the risk factor, or every 2 years between age 40 to 50, and that should be covered by insurance. That's the 2026 guidelines. Now, I had briefly mentioned about home-based HPV screening, which is a commercially available test that can be done at home. So people who are not compliant to come to OBGYNs for pap smear, or they are scared for, they had a past bad experiences, some people with vaginismus, etc., who are not very comfortable getting their vaginal examination done. Home-based HPV screening is approved. ACOG has a very different view on this because what they are worried, if people will do home-based HPV, it might not pick up, so they will give false satisfaction that they are doing a screening. Secondly, if they do find it, they might not be able to follow up with the proper care. So that's the guidelines. They are a little skeptical, as they should be, with home-based HPV screening as a screening modality. Multi-cancer detection testing, there are multiple testing available. These are the commercial names of that, but they are not FDA approved yet. So that's my talk here. Thank you for listening, and yeah.
Thank you, Dr. Gaur. Fantastic presentation. I really like the way you did the information. Even an internist like me can easily understand and go through it. I think I strongly believe that every physician should be up to date with this recent advancements in GYN cancer screening. Because of the timing, we'll ask the questions at end of the third speaker. Okay, thank you. So our next speaker is Dr. Satya Krishna Swami. Dr. Krishna Swami, please start sharing your screen. She is a professor in Department of Medicine and Director for Fellowship Training Program in Division of Endocrinology, Diabetes and Metabolism at University of Louisville. She serves as the Chief of Endocrinology at Robley Rex VA Medical Center in Louisville, Kentucky. She also provides comprehensive endocrine care for patients at UofL Cystic Fibrosis Center and at UofL Pituitary and Skull Base Center, and she is also physician lead of UofL Health Hypoglycemia Task Force. Dr. Krishnaswamy has a special interest in clinical endocrine research, diabetes technology, cardiovascular endocrinology, and women's health. She received Leonard Tau Award for Humanism in Medicine, endowed by Arnold P. Gold Foundation. Please join me in welcoming Dr. Krishnaswamy.
Thank you. Can everyone hear me?
Yes.
Awesome. All right. Well, thank you to all the speakers before me. You set up a very high standard for me here. And also to Kavita for such a wonderful, a program, very important program, and to the rest of the CME committee and to the president. So I'm really happy to be here to give this talk. I think anybody in the 140 odd individuals in this group can give the same talk. It's not like, everybody has been, GLP-1 is like universally used these days. cardiology, OBGYN, psychiatry more recently, and many other specialties, nephrology. We've all been using it, neurology. So anybody can do that. But Kavita gave me a very difficult task. She said, Satya, I need you to look at the women aspects of GLP-1. Well, I thought I knew everything I had to know because I've been part of the trials. I've been a site PI for many of the landmark seminal trials since 2010. When the first CV outcome trial came in 2010 is when we started doing it on liraglutide, and then on pretty much most of the trials that I've been part of. But Kavita, thank you for the task because I learned a lot while I was doing this. So thank you for that. Before I start any talk, I usually like to dedicate it to an individual or team or patients. And this time, as everyone knows here, we are in war and we have young individuals. And like Kavita said, I am VA. I've been in the VA for almost 20 years now, and a lot of research and a lot of my work I have done there, and see a lot of young men and women and get them through different phases of life. And these are the 12 or the 8 men and women we lost that I won't be seeing, and that is very sad. So I have a sort of prayer for all these families that have lost. So sharing my disclosures, like I mentioned earlier, many of the trials also with the National Institute of Aging, and more recently some other studies that we are involved in. And moving on, I always do case-based because every one of us can recognize and identify with the case. So this is a person you probably everyone sees in the clinic every day. 310 is my address, and as Kavita mentioned, we have worked together with a lot of different patients. She's an awesome hospitalist, and I end up seeing many of her follow-up patients. So, this is a 49-year-old individual whom I see for several years. She's well educated, has some interest in science, reads a lot. So every time you come in and there's a new guideline and I say, okay, this is the recommendation, she likes to read, know her own facts before getting started on things. So she has a history of gestational diabetes at a younger years and then diagnosed as type 2. And she has a history of non-proliferative diabetic retinopathy. This is important. Everyone here knows about it, that GLP-1, you have to get an eye exam, especially if you're diabetic before getting started. Neuropathy, peripheral neuropathy, which is pretty painful. I have PEF. I put in here because of the more recent CV outcome trials that have shown that GLP-1s do play an important role with or do impact the outcome. So, and hypertension, mild proteinuria. Again, we have GLP-1 impact here. Hyperlipidemia, osteoarthritis. There's some signal there. And obstructive sleep apnea. Everybody knows. Almost everyone knows about the SURMOUNT study, which showed that one of the GLP-1 GIP agonists do help with obstructive sleep apnea treatment. And whether insurance will approve it or not, that's another story for another day. And she's on metformin, basal insulin, DPP-4, sitagliptin, and ARB for her urine, and for proteinuria, and a statin, of course, like Dr. Gulati mentioned earlier. And her A1C lingers around 7 to 8%, and she's happy with it. We do talk about her weight now and then, but she has sort of stayed away and said, I'm good where I am. We'll talk about it later. And that's one thing with patients. It's extremely sensitive. You only want to get permission before asking and making sure that they are okay with talking about it. Well, she goes to a family reunion and then comes back to see me, almost tearful and very emotional, I think after Christmas. And then now she wants to talk all about GLP-1 because she was there and she had all these other relatives, her cousins, all of them looked a few sizes down, much younger and very, sort of pretty clothes and all that. And they were all like, why are you not on this drug? This is how you get it. Has your doctor not spoken to you? So she wanted to know more about this drug, and she had a lot of questions. She had already read a lot about it. And she definitely is like, now I'm ready and let's talk about it. So, of course, this is Serena now in the last year. Everybody may have seen this commercial in some of the big advertisements places. So, one thing she had read and she talked to me about, which she felt was important, was fuel efficiency. You may wonder, how is GLP-1 and fuel efficiency related? Well, it is in a way. One of the recent reports showed that weight is one of the biggest drivers for fuel efficiency in the space when in the aerospace. And certainly when Boeing and all the other manufacturers, when they looked at fuel efficiency, they look at what is called as operating empty weight minus the weight of the plane before passengers, cargo, and fuel. And obviously, when the passenger weight is down, that actually creates better fuel efficiency and it improves the share profit. So this is like a good thing about GLP-1, which we don't hear about. We do hear about all other positive issues like cardiology stuff and nephrology and everything else. But on the flip side, we just came off our Winter Olympics. Me and my husband, we love watching the ice skating. You know, I've been fascinated by it since I moved here. WADA, which is the World Anti-Doping Agency, which has endocrinologists do play a big role there because there's a lot of drug testing, there's a lot of hormones used, and many of them can't be detected. So you're always chasing a new assay trying to detect it. And this plant-based sterols used all kind. Well, interestingly, this year, GLP-1 made the list. And the reason GLP-1 made the list was because this has a GLP-1, especially in competitive sports where there is figure skating or ski jumping, where weight matters, that GLP-1 use or abuse can be a fair advantage to the athlete. However, everybody here knows that with weight loss, there's also muscle loss. So whether it's advantage or not, we don't know. But certainly it's on the list, not as a drug of abuse, but certainly to be there just to screen athletes who shouldn't be on it if they don't have the indication for it. So my patient, and I believe in this because I do a lot of diabetes, a lot of hormonal issues, thyroid, insulin pumps, technology, pituitary. So there's a lot of education involved. Less procedures, but a lot of education involved. So my dictum is whoever knows the most lives the longest. And that was Dr. Jocelyn, who created the diabetes education a long time ago. He's a pioneer in this, and that is sort of something I use. So we sat down and went over the mechanism and talked about it. She's always my last patient in clinic, so we can spend more time. She has a lot of questions and likes to talk about it. So that brings us to my objectives for today. Understand the basics of GLP-1 and incretin pathway, examine the wide spectrum of implications, and evaluate gender-based considerations and the impact of women's health. Given the limited time, I won't be able to cover a lot of stuff, but certainly this is an ongoing discussion. You can always come back in a year or two where we'll have more data. So the areas of interest would be indication, contraindications, procedures, which I know many of my anesthesia colleagues are in the audience, and we all work together collaboratively at UofL Health. So pre-procedure 2 weeks prior to, if any procedure requires patient to be intubated or have general anesthesia, usually you stop the GLP-1. That's important, something for the patient to know. I tell them always that. And also an SGLT2 is 72 hours. And what is the impact of any gender-based differences in weight? And the third issue is PCOS reproduction, which we talked a little bit about it earlier. The speaker just elegantly presented the cancer risk. And menopause, which is very important. About more than 1 billion women worldwide are going through it, 1.5 billion to say the truth. So skeletal impact, is there any, if there is? And breast cancer and other cancers, and psychosocial and substance abuse. So just to look at the percent of GLP-1 use, Interestingly, this is RAND is a sort of population research surveys that are done, and this is within the last year. They surveyed about 9,000 people, and about 1 in 5 had used GLP-1 in the past year, at least once, or maybe samples, who knows, or we don't know. That's about big number about, and then among them, when they broke down how many, what age groups, male, female, interestingly, the biggest number of the group of folks who used it is women in their 50s to 60s, which is sort of fits my patient here, right? So 20% of them, so which is a big number. Whether they continue to use it or not, that's again a different discussion. So that brings us next to the physiology of GLP-1, which is a very interesting story. I tell my medical students and everybody, it's the story of Beauty and the Beast, because it all started with this Gila monster, which is in dry, arid areas like deserts. And it creates this incretin called as exendin in its saliva. When it eats once, it can be full for 6 months. And we all wish we would feel that way, at least for a day. I know I can't. So this is a perfect match where there's a hormones in search of a function and the function in search of a hormone, which is satiety. And then it also does something very unique, which is when you, in the 60s, when they did this experiment, when they used IV form of glucose versus oral glucose, this little increment insulin production with oral glucose versus the IV is called the incretin, and that's where the name came from. It's an increment increase in insulin when you do oral. And this incretin agents, which is the GLP-1s, are made in your small intestine, the L cells. And that is sort of the interesting story about the incretin sort of discovery early on. And they have very interesting impact pretty much head to toe everywhere. There's first, they used to be called the triumvirate, then the quartet, and then the quintessential quintet, and then the sextet, and then the substicida, given all the different, they impact the islet cells with insulin production, then they improve muscle uptake of glucose, and then the next is increased or suppress glucose production. These are all mechanisms diabetes happen, and the incretins impact every one of this. Hepatic glucose production, and we all know now it's been approved for fatty liver disease, which is called as MASLD. And also the increased lipolysis that you see in diabetes, it does impact that. And also improving the incretin in diabetes, there's decreased incretin production, or whatever is produced, there's increased breakdown and there's more insulin resistance. So when you give exogenous incretin, that does improve your incretin effect, and increased glucose reabsorption in the kidneys. The kidneys are a big area of gluconeogenesis. We all know that, and this prevents that glucose absorption. And of course, suppression of glucagon secretion, which again in diabetes, there's a crosstalk confusion, and there's more inappropriate glucagon production, which can also cause hyperglycemia, and incretins do impact that. And most important final is the brain. End of the day, everybody can stay healthy. We can fix the other health issues, but dementia is very powerful. We are still trying to find ways to prevent. It costs a lot. I have had personal experience recently with my dad, and healthcare wise, everywhere there's expensive costs, so it's very important. This is sort of going over the the GLP-1 discovery to treatment. And interestingly, it started off in 1980s, and we are here right now in the mid-2020s, where we have established treatment of cardiovascular outcome, HFpEF, peripheral arterial disease, kidney disease, MASLD, and Alzheimer's. There is some sort of signal there, and also several other areas that we are looking at. And since it's a women's symposium, I have to mention this. And I don't know if many know about Svetlana Mosov, who was actually part of the. This is a very interesting, narrative about this in Science, where she was part of the discovery, but then towards the end, unfortunately, was left out of the mainstream discovery team. So that is, something to sort of highlight here because it's such an important discovery. And 2026 ADA, just like every year in January, they'll release the recommendations for standard of care. And this year, in the last 5 years, actually. And these are the extensive aspects. And I encourage if anybody has the time and energy to read some of them. It's very extensive and there's aspects for everything: pregnancy, children and adolescents, older adults, inpatient, complications, psychosocial issues, advocacy, etc. And here is the algorithm in the last 4 years. It is very cardiometabolic based. So you always start not with just metformin. Many of them of course, you do the healthy lifestyle behaviors, just like the first speaker, Dr. Gulati, spoke about. But the goal is cardiovascular kidney risk reduction. So there, the GLP-1 RAs come right in the forefront, along with the SGLT2. So I just wanted to highlight that. Hopefully, we'll have better coverage with insurance companies with that. And these are some of the trials that, also I've been a part of, but these are the landmark trials. Sustain 6 is the study with semaglutide, where it was shown that the CV outcome impact with semaglutide. Flow is the renal study. In fact, when they were doing Flow, we were doing Select. The nephrologist and the endo and the were in the same room with talking about the outcome study. And STRIDE is a more recent publication that came out looking at peripheral arterial disease and GLP-1 impact. And all these, the primary endpoint, the initial SUSTAIN studies, the primary endpoint was A1C reduction. The later ones were CV outcome studies, but the secondary endpoints were weight and A1C also. So with this in the background, let's look at some of the differences. So this is SUSTAIN 6, which is the first CV outcome study for semaglutide. And men and women, they were almost similar. Interestingly, the SELECT, which came later, almost 70% were men. There were not enough women. And that is something going back to what we discussed earlier about representation of women in the studies, major studies. So here, it was pretty universal. The impact of CV outcome was pretty universal. There was no gender differences. Men and women, similar outcomes and no difference. So that was something important to know. And I just mentioned SELECT earlier. And this, again, it was mostly men and not enough women. SELECT was looking at efficacy of semaglutide with pre-existing heart disease and a BMI of over 27, but no diabetes. SUSTAIN looked at diabetes. SELECT was non-diabetics, but higher BMI. And there also, there was a pretty powerful impact. And thanks to this study, we are able to get GLP-1 for our patients who are hospitalized with heart failure. Hopefully, insurances are willing to cover these days. At least 2 years ago, it was approved. So looking at this slide is from Bob Kirshner, looking at the outcomes, gender, ethnicity, race, age-based. And I would bring your attention to the results of, this is a step 1 study looking at Wegovy, which is semaglutide 2.4, body weight and impact on body weight. And this one didn't show, it does show some preponderance towards women, female sex, or being white. And also, if they had a lower baseline body weight and normal glycemia, they had a more brisk response. So that's something I shared with my patient that, being a female is an advantage to be on GLP-1. You do have better response. So that is one of the first sort of data that I had. This is, let me just remind everyone that there were no separate female studies done. So most of the women-related outcomes were meta-analysis. So it's not prospective or RCT. So this is 14 studies that someone looked at and looked at outcomes for weight. And interestingly, again, here, the GLP-1 reduction is much more pronounced in women, especially the more weight was lost, the bigger the impact of gender differences. So that is the second study. And interestingly, as Kavita asked me to do this, then JAMA published a very interesting study, which has been become widely read now. It's by Alexander and group. And these were I think they were from Johns Hopkins. At least the epidemiologist, Dr. Hemant Kumar, is from Hopkins. Mehta is his last name. So this one was 64 studies, 64 different studies, and a meta-analysis of all of them. And I would like to bring your attention. I mean, they looked at different things like age, race, ethnicity, and gender, of course. And of course, here this established everything we knew already. Women do respond better to GLP-1 with the weight. Now, why is the fairer sex at a bigger advantage? Well, it's probably the estrogen. That's one thing. I won't go into details of everything because of interest of time, but estrogen and GLP-1 in terms of the hypothalamic receptors and everything, there's a lot of similarities and the energy expenditure, etc. So GLP-1 is more powerful. Not only that, this study also showed that, let me just go to the next slide. So there's a synergism, like I mentioned earlier, and there's a smaller mass in the women. So with the same fixed dose, they get a sort of a more bang for the buck. And also, there's a higher adipose fat content compared to men in terms of body composition that is seen in InBodies and DEXA scans. Now, none of the studies really looked in detail into all this. Like we used mostly waist circumference and weight and neck circumference later on, but we didn't use InBody. More recently, we are using a lot more InBody. So for each unit reduction of BMI, whole body fat, the women tend to lose a little bit more. But they also, in the process, there's also some muscle loss there. So that's important to remember. So I already mentioned the CV outcome studies. The CV outcome endpoints were no different, men and women overall. But we haven't sort of broken down into different areas yet. Next, I'll go to the pregnancy aspect of our reproduction aspect and menstrual regularity. This is again a meta-analysis going back and looking at several studies. And this is something everybody here knows, and definitely many of our physicians who take care of young women probably know that, who have them on GLP-1. The cycles do become more regular, like you can see here, it's favorable. And also, not only does that get better, this was more like a 12-week duration and a 1-year duration, different effects. Not only did that get better, there was also, what got better was also insulin sensitivity, HOMA-IR, which is HOMA insulin resistance, anthropometrics, and total testosterone levels also got better. So there is certainly a signal there that it could be, but we don't have studies just looking at that endpoint. We should have something pretty soon. The next aspect is fetal impact. Fetal impact, these are, mind you, these are animal studies. We do not have, obviously, we wouldn't be studying pregnant women and GLP-1, but we've had some surprise Ozempic babies. Despite my education and everything, cautioning patients, they do call back and say, hey, I've tried to get pregnant 20 years, I couldn't, and now I'm pregnant 6 weeks into the GLP-1. So we've seen a lot of Ozempic babies, and I've encouraged everybody to say, if you get somebody and they're pregnant on a GLP-1, have them call FDA or call the company so they can get in the registry, because we are collecting this data. Now, these are animal studies. This did show that when there is GLP-1 use during pregnancy, especially late trimester, there was several impacts, especially the bigger concern was fetal congenital anomalies. there was visceral congenital anomalies, delayed ossification, and also decreased or small for gestation. And these are animal studies. But certainly, we don't have clear human studies, and the few case reports we have, things have been okay. So, what are the effects? We don't have all the human data, but there are a lot of gaps in knowledge. We know that it can impact weight because maternal nutrition is compromised, so there may be impact of weight, and there may be other impacts also that may come up later in life. So we do not know that. So, and what about the fetus during gestation? Well, it is recommended that any woman who is planning pregnancy at least stop it a few months ahead of time. Definitely make sure there's a washout, number one. Number two, also to educate them, there could be, because of the nutritional issues and absorption issues and micronutrient issues, there could be late gestation effect and also lactation. We recommend at this point not to use GLP-1 with lactation. I have a lot of patients who want to resume back, and I say no, not at this point. So mainly because, well, it's ingested, but you do not know if the fetus, the infant will have any impact with that. So those are important areas to discuss with every patient. There's not enough data, but at this point, there is concern, so hold off for now. So, and then I will skip this part and go to the malignancy. Well, we don't have very many information, but we do have, again, meta-analysis. That's why you see a lot of forest plots here. Interestingly, just to summarize this study, tirzepatide, which is GLP-GIP combination, showed some protection against hematologic malignancies. Now, this didn't talk about solid tumors. And dulaglutide, there was a slightly higher signal for lymphoma, but all others were in between. So there's more to come later. But there's some interest looking at breast cancer, given it's a women's symposium, because we all know obesity is one of the risk factors for breast cancer. We are very interested in if GLP-1 somehow can help mitigate the risk, or even post-treatment. We have many patients, we have sort of looking at programs where they gain a lot of weight. We deprive them totally of estrogen. They go through immunotherapy, a lot of treatments, gain a lot of weight. So can they be approved to automatically start having GLP-1, get started? So those are discussions we are going through, and talking about prevention versus treatment once they've had the treatment done. So that is about the cancers. Bone health, skeletal health, it's very important at all stages of life, mostly in perimenopausal areas. There's 3 different bone health discussions. One is the diabetic osteoporosis, because this drug was initially for diabetes. And then the next is the postmenopausal impact, which is more universal, and then the steroid induced. Well, we don't have any prospective studies, but there's a lot of interest looking at GLP-1s. As you can see here, this is your bone pathways, looking at the Wnt signaling, AKT pathway, the MAP kinase, and GLP-1 seems to have an impact in many of those in vitro studies. So there is interest looking at what it's going to do. But if you think about GLP-1 as knifeless surgery, where they lose tons of weight after bariatric surgery, your fracture risk goes up. So we do not know what biochemically what the impact is, but when you lose the weight and lose muscle, is there a higher risk for fracture? So, and also absorption issues with micronutrients. So there could be both sort of aspects we have to think about. Substance abuse is important, especially we live in Kentucky. We have a huge problem with this. I couldn't see any particular studies looking at women, but this is a veteran study, and I thought it was very interesting, so I put it in here. Is looking at veterans with substance abuse program, and it showed that there was some impact on readmissions, risk of developing, and also overdoses and deaths. And we all know there's been a study looking at alcohol use disorder also. There's some interest there. So I'll skip this part because in the interest of time, one thing I wanted to highlight to my patient, to everyone, is whoever starts, and this is a study that just came within the last 6 months, the percent of discontinuation. It's pretty high, almost 50%. And most of it is usually finances, but side effects also do come by. And interestingly, the Asians had a higher risk of discontinuation in the study. So that is something to also consider. So best responders, well, it's the female sex, higher baseline BMI, higher A1C, and shorter duration of diabetes predicts better outcomes. Poor responders, those with insulin deficiency, may be misdiagnosed as type 2, but actually type 1. And treatment variability, about 30% of the patients can fail to achieve this, and this is where that interest is. There are more drugs to come in pipeline, and I will leave it at that. And GLP-1 now very heterogeneous and very sort of universal use in various systems. In fact, just recently, my urology colleague contacted and said, can we look at GLP-1 and kidney stones? So we are putting together a VA award trying to see that. Of course, there are the concerns with the GLP-1 phase. And then recently from Australia, there was a study looking at scurvy, which was from the 1700s. So this being a nutritionist week, shout out to my wonderful nutritionists that I have in clinic, that you need to make sure they are talking and discussing with the dietitians. And building muscle, exercise, just like both the speakers spoke about, it's very important. Compounding is a question I get asked all the time. Being in the university and participating in studies and going by FDA, I do not prescribe, but at the same time, I tell the patient, I leave it up to you. So the patient then turned around and asked me, so have you taken it or any of your colleagues take it? I said, I'm not going to put the female colleagues or Oprah Winfrey here, but I'll put my male colleague who's a nationally known diabetologist, very actively known in ADA, Dr. Buse, and his colleague, one of the cardiologists, Darren McGuire, put it in. And this is pre and post GLP-1 use of Dr. Buse. So I'll tell him next time that I let him, put him on the news here. And I always use a dot phrase in the clinic so patients understand and know what I'm talking about. And I will stop here and thank you very much. Sorry, I skipped through a few slides, but thank you, Kavita, for the opportunity. And I hope we all together learned something today.
Great presentation, Dr. Krishnaswamy. I know this is a very popular topic, especially in women these days, and you did a great job presenting it.
Thank you.
Let's go to the questions. I have a few questions for Dr. Hetal Gore. Let's see.
Let me unshare my screen first.
Sure.
Let me see. How do I do that? Oh, here we are. You can go ahead, ask the question. I'll unshare.
Dr. Gore, this is the question for you.
Sure.
What should be the yearly screening protocol for a post-menopausal woman with dense breast tissue with no risk factors and negative family history?
So yeah, they still need the annual exam, as I said. They should still go to the annual exam for clinical breast examination. And as far as the pap smear is concerned, if they have a 3 negative pap and they never had a history of high-risk HPV, then they can skip and they can not do pap smear anymore if they are 65 and above.
Okay.
But they need to have 3 negative pap and no history of HPV. If they have a history of HPV, they still should get it every 3 to 5 years.
Okay. And the next question for you is coated IUD plus ERT patch a better option than micronized progesterone?
So definitely one has to look into the risk factor. If they have a risk factors which are estrogen related, right? Then just progesterone is okay. So without the clinical history, it's hard to say.
Okay. And the next question for you is, what are the guidelines with family history of ovarian cancer?
Oh, so family history of ovarian cancer, definitely one should get the transvaginal sonogram done, CA-125, the MUC, which is the new genetic testing, and definitely go for, the examination annual 6 month to a yearly, where we do a pelvic exam as well. So that should be done.
Okay.
for screening. They should definitely do BRCA testing as well, the genetic cancer screening. And if they are positive, as soon as the childbearing is done, they should do a prophylactic salpingo-oophorectomy.
And the next question for you is ASCUS with a negative HPV. Is PAP recommended 3 years or 5 years?
So if they, if they never had any history of HPV, you can do 3 year if it's only PAP, and you can do 3 to 5 years if you are doing co-testing.
Okay. And then they're talking about lung cancer. I don't know, but has the incidence of non-small cell increased in non-smoking Indian females above 65?
I don't have exact data for that specific subgroup of like Indians and small cell. I would defer it to a cancer specialist if Satish is here. But as far as I know, when I was reading about this to present, I didn't see that. But I will, as I said, I'm not expert in that. I'll leave it for him.
Thank you, Dr. Gaur. I have a few questions for Dr. Krishnaswamy.
Yes.
Why does the weight loss stop after a couple of weeks with GLP-1, and what can be done to restart weight loss?
So thank you for that question. Typically, there's a plateau effect. We didn't go in 20 minutes. GLP-1 is like a year literature. So, so there is plateau many times, and there's a dose escalation protocol. And for me, I never follow the dose escalation protocol all the way, because after doing and being part of these studies, I realized every person is different. So it doesn't work. So sometimes the insurances don't cover if you didn't escalate it every month. And I tell them, no, it depends on the patient, not what you can't dictate what we do. So I usually then look into how they're doing it. Are they having side effects? Are they incorporating exercise, diet, and other issues? And if they have undiagnosed sleep apnea or anything else that is holding them down. So.
Okay. And the next question is,
Kavita, I saw a lot of people, one question about oral semaglutide or Wegovy, and someone else already answered that. And it's available anywhere between 4 milligrams to 50 milligrams. The study was out last year, and it's available universally now for oral. My take with the oral is, you have to take it on empty stomach first thing in the morning, whereas the injectable is once a week with a pen. So it depends on what people prefer. And then if you're on Synthroid and then oral Wegovy, then you have to time it. And if you're doing it together, then you have to adjust the Synthroid dose, so thyroxine dose. So.
Okay. And the most common side effects forcing discontinuation of these medicines?
Yeah, that is also very interesting. And that's why I have that long dot phrase that I use, going over things like, I tell them this is knifeless surgery, so they get the picture that it's like having bariatric surgery, except they didn't use a knife. So changing the diet. So usually the first meeting is usually with the dietitian, then talking about exercise, other healthy lifestyles, although many patients already have done that and they're prepared to get started. And then the biggest thing I tell them is the weight loss journey is your journey. Don't get harassed in blogs and websites, because people do a lot of harassing of patients, like cyber bullying. So, and then we also go through, like, many times you may not lose the weight, but you have changed your body composition. So I tell them, measure your waist circumference and look at, your lipids look better, your blood pressure is better. Those are several aspects, and everybody is different in the way they respond.
Sorry, I just saw there was a question about Cologuard versus colonoscopy. I think I did cover it in my talk, that I personally see that a lot of patients prefer Cologuard because it's convenient and no sedation. But I think the recommendation is colonoscopy is still the standard of care. But if they are not going to do it, I would rather say at least get the Cologuard done. Yeah.
Okay. Thank you, Dr. Gaur.
My question I have for the Dr. Satya, is oral as effective as injectable GLP?
So, again, the study showed a good outcome. but again, it's the compliance part of it. Oral is never, it's a everyday one more pill burden added. So, but some of them have needle phobia and would rather do oral. So those are the different aspects of it.
But efficacy is equal.
Yes, efficacy is pretty equal. And we have had the CWAT studies also on the oral, so we know there is some, especially with the Ribelsis, the Ozempic part of it for the diabetes. So we know it does have the CV outcome. So
does it improve left ventricular ejection fraction and GLS scores with preserved and compromised left ventricular ejection fraction? So they're talking about whether it will improve the ejection fraction.
So it's used, it's been based on the SELECT study. It has been approved in for HFpEF. In terms of details, it's mostly it prevents frequent hospitalizations and decreases death. Those are the outcomes mostly that have been looked at. In terms of does it improve ejection fraction? I think the SGLT2 has a better, stronger sort of aspect to it. The way they look at it is SGLT2 is more volume sort of thing, and then the GLP-1 is more like the adiposity, the metabolic, the sort of atherogenicity, those areas. So they both have their roles that they play. So.
We talked about estrogen, so they're asking whether GLP-1 effective in postmenopausal women as much as it does in premenopause.
Yeah, that is, I saw that and I thought there are very, very interesting questions which could be applied to future studies in this chat, I'm not so sure. And I see what you're saying because of the estrogen factor, is it more powerful? But in the studies, many of our patients that were in the studies were not very young women, because at that time we didn't want women in childbearing group to be in these studies because of the pregnancy risk. So most of the women there were, into perimenopause or postmenopause. So.
Okay. Any updates on GLP-1 with the weight loss in people with no comorbidities?
Wait, maybe one or two questions. We need to wrap it up.
Last one.
Okay, good.
Without comorbidities, yes, those were the first initial studies, the STEPS and the pioneers. It's been used as weight management. It's just that insurances don't want to pay for it if you didn't show, if you didn't say they had sleep apnea or HFpEF or, something related. So, yeah, or MASLD, those are the three approved for now. So I think more would be on the way. AUD, alcohol use disorder, may come in the future. So.
Okay, thank you so much. I know I missed a couple of questions because of the time restraint. And there are a lot of comments on all three of you guys, how great your presentation is. You're wonderful. Thank you so much again for doing this. And hopefully we'll do it again soon.
Yeah.
Thank you very much.
Thank you
really
all.
credit goes to Kavita for arranging this just within a month or so. She pulled it all together. And great speakers we got. This is really amazing. Would like to learn more at the annual convention, sure. And next year too, we will do this again, whoever is going to be the Women's Forum. I would say that we have not really lined up for the April, but Amit and I were still thinking. And in May, we are going to do somewhat near to this topic, which is lean diabetes and some of the other topics related to that. So we'll come back to that, diabetes, lean diabetes, etc. Amit, you want to conclude?
Yeah, thank you so much. I mean, I agree with everybody, and this presentation was awesome. I mean, really topped one of our best CMEs of this year. And the one of the main thing was because it's covered diverse topics, and which is actually pertinent to women's health, and there's a lot of interest in this. And speakers were awesome, excellent speakers, and beautiful presentation. I really applaud it. And Kavita, as usual, you pulled it off. You have always done a great job as a women's chair. I'm looking forward to a stellar women's forum in the convention. Again, convention is July 2 to 5. AAPIconvention.org. Program is not posted there yet because we are working on the fine details. However, everything else is there. Registration also is going to open in a couple of days, few days within this week. Definitely, we're just making the final touches. This is obviously not a like a pen and paper registration. It requires a lot of things in the background, and we're trying to make this convention a convention worth remembering. Make this a family trip for yourself. Just come on Saturday, do the whole week. That's another option for everybody. We can if that happens, we can actually try to plug in some activities. What we are doing for families also trying to get free or discounted Tampa attraction tickets from Tampa Bay. As you know, this is the 250th year of independence. So Tampa City is rolling out the red carpet. We are going to have such a great welcome by Visit Tampa Bay that you'll be really really pleased and surprised. They are actually going to put our logo Namaste AAPI Chalo Tampa in everywhere in their city, and that's going to be awesome. So please try to attend this. This is going to be great. We have got great entertainment also lined up. We got great CMEs lined up. Big celebrity speakers are coming up. We're just not yet. I want to get it. I just don't want to write that invited, because what happens in the past, what has happened when they say invited and people don't show up, I only want them when they commit by email. That's when I put the things on. So as you know, we are going to have Kumar Shanu, Vishal Shekhar. We've got amazing, big celebrity speakers from here and India, and also working on trying to get the health minister also from India coming over. So it's going to be a great convention, guys. Please register, please, when it opens up, and looking forward to that. And the next month's convention, CME, will also be on the same time, same third Sunday, same time. Only thing is that what the topic, which most likely Tarak will go with the ER emergency room thing. I think
Okay, no problem.
that's been an interest last time also when I was the CME chair a couple of years ago. I think we'll get that. So it most likely will be on emergency room based thing, which will be of interest to everybody. So thank you again. Don't want to keep you too long. And somebody raised their hands. Anything? I don't know if it is related to the convention
Yeah,
or
it's
something.
related to the topic, I think.
Topic. Okay, good.
Yeah.
All right, sounds
Thank you,
good.
Dr.
Thank you.
Chakravarti. Looking forward to seeing you guys in the Tampa convention.
All right, great.
Bye.
Thank
Bye,
you.
everyone.
Great guys. Good job,
Thank you.
everybody. Such a good speaker.
Thank you,
Thank you.
everyone.
Thank you, everyone.
Bye.